Good morning, everyone. Thank you for taking time out of your busy day. My name is Chris Marr. I'm the Director of the Institute for Musculoskeletal Health, and that's the group that's hosting today's webinar. We're just waiting for a few more people to arrive. I think at the moment we've got about 104 participants and we had about 600 enrolled. So maybe I'll just give a brief introduction to the day and hopefully that'll give time for people to join the seminar. Before I start today, I'd like to acknowledge the traditional custodians of the land on which we meet. So for me, it's the Wallumaldergal people. I'm at Epping in Sydney. I would like to pay my respects to elders past, present and emerging, and also acknowledge any First Nations people who are attending today's webinar. Just to give you an introduction to the Institute, we're a collaboration between the University of Sydney and also Sydney Local Health District, and our vision is to optimise musculoskeletal health and physical activity. The group that looks at, I guess, the research theme that's featured today is led by Professor Cathie Sherrington, and that's the physical activity, ageing and disability stream. And they look at, I guess, a range of issues, but just to give you some statistics upon the nature of the problems they deal with. In Australia each year, 100,000 people are hospitalised with a fall, and fall injuries are increasing by 2 to 3% per annum. So it's a problem that we need to do more for. And so we do have some solutions that are being rolled out. The one that I wanted to point to was the CRE that Cathie's leading. So she's got a new CRE for $2.5 million, which extends for the next 5 years. And so I'd like to pass to Professor Anne Tiedemann. Anne, could you take over?
I will. Thank you very much, Chris. It's my great pleasure to welcome you all to the webinar today and to introduce you to our speaker, Professor Sallie Lamb. So Professor Sallie Lamb is the Mireille Gillings Professor of Health Innovation at the University of Exeter. She's also an Honorary Departmental Professor at the Nuffield Department of Medicine at the University of Oxford. Previously, Professor Lamb was Director for Centre for Statistics in Medicine, Foundation Director at the Oxford Clinical Trials Research Unit, and Centre for Rehabilitation Research at the University of Oxford. She has a long-standing interest in clinical trials, medical statistics and rehabilitation of musculoskeletal and chronic conditions in older people. She works with clinicians to develop pragmatic clinical trial designs to capture the effectiveness and cost effectiveness of a variety of health interventions. She's the chief investigator for a number of trials of rehabilitation interventions. Professor Lamb has served as board chair for the National Institute of Health Research Health Technology Program, and she's a fellow of the Academy of Medical Sciences, Royal Statistical Society, and Chartered Society of Physiotherapy. She served as a member of the American Geriatric Society and the British Geriatric Society Fall Guideline Panel and the NICE Guideline Panel of Hip Fracture Management. So today we're really fortunate to have Professor Lamb presenting to us about the results of the Prevention of Fall Injury trial that was recently published in the New England Journal of Medicine. And so the format for the webinar is that Professor Lamb will present to us about her trial, and we'll then go to our expert panel who will ask questions and have a discussion about the study, and then we'll open it up to the audience. So if you have questions, just pop them in the Q&A and we'll get to them later on after the presentation. So I'd like to hand over now to Professor Lamb for her presentation.
Thank you very much, Anne. And can I just check, can you hear me okay?
Yes, sounds good.
Yeah. Yeah, that's great. Lovely. Well, thank you very much for inviting me, and it's really nice to join colleagues from Sydney and from further afield. I'm going to talk for 20 minutes on the Prevention of Fall Injury trial. I'll cover the methods and the results, and it'll be great to discuss, to hear your thoughts and get some feedback on what is quite a complex study and message at the end of the day. So what was the Prevention of Fall Injury trial? Well, for quite some time, we have noted that there's a lack of evidence of the effectiveness of fall prevention strategies on fractures and serious injuries. And it's one of the kind of things that has really stood out in the literature for quite some time, and the need for a trial has been well recognised. And in fact, there have been 2 trials published almost at the same time, one by some colleagues in the United States who actually we collaborated with, and that was the STRIDE study. And then very soon after, once the New England Journal of Medicine had managed to interpret my written English, we finally managed to get the second study in alongside that. But neither of them give a very rosy glow, and I think we've really got to kind of reflect and think about what we're doing in this space. So what was the aim of the PreFIT study? It was to estimate the comparative effectiveness and cost effectiveness of screening and targeted interventions for fall prevention on fracture rates. And the interventions were postal advice, which is the control, plus or minus screening, and targeted exercise or multifactorial fall prevention interventions. And this was all done from primary care, and the idea was that it was a population-based approach. So this would certainly have been something that, if successful, we could have scaled up really in quite a straightforward way in the UK. We wanted to have a look at the relative effectiveness in subgroups by age, sex, frailty, and fall history. And as I've already said, we wanted to look at the cost effectiveness. So what did we do? Well, we did a 3-armed cluster randomized trial. The setting was primary care. We set out to recruit 60 general practices. In fact, we recruited more, and a minimum of 9,000 participants. And that was to give us the power to look at fracture as the endpoint. Participants were to be aged 70 years and older, community dwelling. We excluded people from nursing or residential homes and with terminal illness. And the primary outcome was fracture. And we had a limited number of secondary outcomes because it was such a big trial. But we incorporated self-reported falls, quality of life, frailty, mortality, and healthcare use. This just gives you an overview of what the trial looks like. So in the end, we recruited 63 general practices and 9,803 people we kind of managed to over recruit a little bit. Now, this is a really important element of the approach. We took a random sample of participants to invite into the study from GP practice lists. So we've got a really nice kind of unbiased sample, or reasonably unbiased sample, and we aim to recruit 400 participants per each practice, and for about 200 to 250 to accept. So the participants were identified and consented prior to randomization of the practices. That's a really important element of cluster randomized design. The clusters were then assembled, that's the practices, and they were randomized to the 3 groups in equal proportion. And what you can see here is that we use the Age UK leaflet. I mean, really, that's a booklet, not a leaflet. Very extensive advice on falls prevention. We use the Screening Plus, the Otago exercise program in the exercise arm, and we targeted the exercise to people at higher risk of falling. And in the MFFP arm, we use the Screening Plus, the targeted, same group were targeted from screening, and we use the Tinetti multifactorial fall prevention training and intervention. So participants were actually asked to participate in a survey of aging. So because it was cluster randomized, we were able to convince the ethics committee that actually it was to the benefit of science and the general public that we would consent people to provide the follow-up data in the format of a survey of aging, but that the practices would continue to provide the interventions just under the course of normal treatment. So this is a really pragmatic study. People weren't aware that the practices have been randomized to different types of fall preventions, just that their practices were interested in falls prevention. That's it, good. Okay, oh, sorry, I'm just going to go back. So what we did was we used self-reported questionnaires, and those were repeated at 4, 8, 12, and 18 months. Because it's such a large study, we couldn't use diary cards at all intervals, so we selected every person to complete 4 months of diary cards once. So we have diary card information, and we were actually able to compare the effects with diary card versus the self-report. And our primary outcome we collected from NHS digital health episode statistics and GP data. So these were adjudicated endpoints. And, you know, we can be quite sure that a fracture had occurred. We had additional data on self-report of fractures, but we didn't use that to define the primary outcome. So, as I've explained, the intervention was screen and treat, and in the intervention arms only, the GP, the general practitioner, sent out a balance screener, which was a single sheet of A4. And it was a self-assessment that was returned back to the general practice. And once the general practice received that back, if the patient participant was at higher risk of falling, then they were invited to the treatments, either the exercise or the multifactorial fall prevention, depending on allocation, by the general practitioners. So again, it was a really pragmatic study. The organisation of treatments was all done through the general practice. This tool was based on a previously validated falls risk screening tool, self-reported, and it's actually question 2, 3 and 4 in that A4 sheet there. Very simple, and actually this is one of the things that worked really well in the study, and it was the one thing that I really thought was the biggest risk with the trial, was that if we didn't get these screening questionnaires back, the study could fall at the first hurdle. So that little bit went well. In terms of the interventions, in the exercise arm, we used the Otago Home Exercise Programme, which I think is very well known to most people. It's strength and balance training for 1.5 hours per week, and that's really to encourage people to do that under their own steam. There were 6 sessions of face-to-face contact with a physiotherapist, and some of those sessions, 2 or 3 of them, could be done by telephone. And the idea of the sessions was that that was the time when the PT would work with the participant to progress or change the exercise regime to make sure it kept moving forwards. And we spaced those sessions out over a 6-month period, and that's quite a long time contact period for the UK. So this was just slightly different, just in the duration, not in the actual number of contacts. So this reflects a pretty good implementation of the Otago programme for the UK setting. It kind of lies in the middle point of what would be usual practice. So participants completed treatment logs and were supported by therapists. In the MFFP, we, as in both arms, delivered training to either GPs, consultant geriatricians, or nurse practitioners within primary care. And we basically trained them in this quite simple approach to multifactorial falls assessment, but that was all done, the training was all done by experienced clinicians. We did allow for different models of delivery, and we had to do this. It's, you know, part and parcel of a pragmatic study. So in some areas, it was delivered by consultant geriatricians, and in other areas by GPs and by the primary healthcare team. The intervention includes medication review, and all of the medication reviews were done either by GPs or by consultant geriatricians. For all of the interventions, we had standardized intervention manuals, laminates, and quite carefully crafted mechanisms to ensure that we could both train people, that was all done face-to-face, and that they had all the available materials as they went through the study. We did a number of quality assurance visits to make sure that people were able to implement the intervention, and then of course to maintain the quality over time. And this just describes the multifactorial falls assessment that the various clinicians used. As I've said, it's based on the Tinetti intervention, falls history, screening of red flags, gait and balance, postural hypertension, medication review, vision check, footwear, and environmental hazards. And some of these risk factors were dealt with within primary care, and some were dealt with by referring people onwards. So there's a really good description of, we've got an intervention paper, so there is a really good description of this intervention, and I can take more questions on it if needed. Those are the papers where we describe the interventions, and also the trial protocol. So we did some process evaluation alongside the study. Again, because it's a big trial, we can't it just means that we can't quite collect quite as much data. We obviously collect data on far more people, but we have data on the screener performance, the uptake and response to the intervention. So we've got all of the treatment logs from both treatment arms, assessment, attendance and engagement statistics, the doses of exercise completed, medications and prescriptions of exercise in MFFP and the exercise arm, and also we can track through the resource use questionnaires where we've recommended that participants went to, for instance, to their optician. We can actually track whether or not they went to the optician or not. They give us that data by self-report. And similarly with the MFFP, we've got all of the referrals recorded, intended actions, medication sub-study, and a reasonable track of information through the study. So the analysis was intention to treat. All participants were included, and the primary analysis really includes all participants regardless of their risk level. We then undertook a stratified analysis where we looked at the estimates of effectiveness within the higher risk groups, which would give you a grouping of about 4,500 people who were at higher risk. And that's, so the that strata on its own is the same size as the STRIDE study. We did a case analysis which looks at compliance. It's a bit difficult to implement in this type of framework, but nevertheless, we managed to do that. And as I've said already, the primary outcome was fractures. So let's have a look at the study flow chart. I mean, I don't think there's a huge amount to say really about this. We approached 29,000 people aged 70 plus, and 34% of them agreed to participate. So 19,000 people did not want to participate. 7 people died between the approach and when we randomized, and 9 people withdrew. But otherwise, we had 9,803 people, and they, as should happen with the randomized study, they're pretty evenly balanced across the arms. This is obviously cluster randomized, so there's just a little bit of bounce, but the numbers are pretty good. As the health economist who has worked on the study for us said, he's never seen a study that's so well balanced, but that's because of its size predominantly. So if we just follow that through, I'm going to show you some of the statistics related to loss to follow-up, but for the primary outcome, because it was recorded through routine data, we have complete data for the primary outcome of fractures. And this describes the areas of England that we recruited from. It ranged from the grim and dark north, Newcastle, where our colleagues in the consultant-led service who've done a lot of academic work in falls prevention did the intervention for us, assisted by colleagues in the community setting. And then into Middle England, where we were in a kind of fairly rural area in the mid-belt of England, Cambridgeshire, and then finally down in Devon, which is my new hometown, beautiful little jewel of a place on the kind of little bottom foot of England. But this area of England has the highest and oldest population in the UK. So if we have a look at deprivation in the UK, we can track deprivation through postcodes. I'm sure it's probably similar in Australia. And what we can see is that we've got a good spread of practices with different deprivation indices. We've got kind of the light pink is Middle England, that's what I like to call it. And the most deprived are the red practices. And some of the areas that we were working in were really deprived. And obviously some are at the top of the scale as well. So we've got a good mix of people, and we think that it's mostly representative of the UK population. In terms of the response rate to postal follow-up questionnaires, I think we got a very good response rate up to 12 months, and then actually wasn't too bad thereafter. It started to drop a little bit as we went to the 18-month follow-up. I think that's entirely to be kind of anticipated, but I was pleased with the response rate, 83% at 12 months, given the approach that we had for these self-reported outcomes was good. So what was the sample like? Well, the mean age was 78 years old. We had a good range. Over half the sample were over the age of 75. And as you can see from the range, you know, we ranged right up to 101. And this is similar, it's just slightly less than the STRIDE study. Their average age was 80 years. We had 53% females and 47% males. And we had 44% of people who were at risk of falling. That includes having balance problems. 20% were frail. 4.5% had suggestions of cognitive impairment on a clock drawing test, and 33% were living alone. So I think we managed to capture kind of a pretty broad spectrum of people. Now, if we have a look at the primary outcome, what you have here is you've got the fracture rates per 1,000 person months. In the blue is the advice arm, in the red is the screen and exercise arm, and in the green is the screen and MFFP arm. And of course, what you have, I don't know if my pointer works, no. What we can see here is where you see the one running across on the right-hand margin, we can see that there's a slight increase in fractures, but no statistically significant difference. And again, that kind of little margin just kind of nips up. Now, my interpretation of this was straight down the line, statistical interpretation. There's no evidence of a difference in fracture rates. Some purist people would suggest that there's an indication that the fracture rates may be increasing in the two intervention arms, but yeah, as I say, I took the purist tack, and I think that it's the correct interpretation. I think one of the things that surprised me about this study and gave me real insights that I hadn't had before, I assumed when you scale data up, the picture would become much simpler, but there is, you know, kind of still quite a lot of variability in falls rates. They're quite variable events, and people are also having lots of other events in their life. So it was an interesting data set for me. I kind of thought, oh, okay, this is not that easy to deal with. If we look at falls, this is the bit that the New England Journal wouldn't really let us report on. And I thought it was a very important part of the study interpretation. Again, we've got the same color coding go on. Blue is the advice, red is the exercise, and green is the MFFP. And we had some little differences in falls that were at baseline that were adjusted out. These are some of the outliers, but I can talk about those separately. We've dealt with them pretty well. What we can see from this slide is that as we cross time, we have some kind of time episodes when the falls rate actually reduces, and that's statistically significant in the exercise arm. But there's no evidence of a reduction of falls in the multifactorial fall prevention arm. So this to me was an important piece of information, because it did show that whilst the effect wasn't sustained, we did actually reduce falls. So for me, the interpretation, this helps in some way to interpret the results. You know, we reduce falls but not fractures. So that's quite important. And in terms of cost effectiveness, what we found was that the exercise overall was the most cost effective component. So it always delivered more quality of life gain, always in the following order: exercise, advice, MFFP. So MFFP had the lowest quality gain. And if we looked at costs, that was reversed. MFFP had the higher costs, then advice, and then exercise. Now, these are not very large differences. I kind of underscore that. They're not large differences, but, perhaps we wouldn't expect these differences to be that large in this context. If you have a look at the amount of healthcare contact that this cohort has overall, you just realize, kind of actually falls, whilst important, I'm not going to say it's a drop in the ocean, but it's quite a small sliver. You know, there's an awful lot of contact that happens because of, say, cancer and these types of things. So these are definite, you know, it's definitely more cost effective, but as I say, it's kind of small gains, but low cost as well. So it doesn't cost much to deliver an exercise intervention in this way. I'm just going to ask you, Cathie, do you want me to carry on? I'm just about up on time.
I think it'd be great to carry on. Let's hear more from you, Sallie.
So I'm going to look a little bit at the process data, because it starts to give us some insights into what may have gone right and what may have gone wrong here. So in terms of postal screening, as I said already, this was the thing that I thought was the real kind of weak link potentially in the study, but we had a really good response to postal screening. So 88% of the cohorts who were asked to return the screener actually returned it, and we got a good spread of responses across all of the different risk categories for falls. So it ranged from 85% of those who were at higher risk to 90% of those at lower risk. So there's a little bit of slightly fewer people in the higher risk category, but still really good. There was no difference in age, gender, living alone, and BMI between those people who responded and didn't respond, but there were small differences in deprivation and frailty. And you were less likely to respond if you were in a deprived area, and you were less likely to respond if you were frail, and you were slightly less likely to respond if you were at risk. So they're quite small differences. They're there for you to see. And the non-responders were equally distributed across the treatment arms. So again, that was good. So postal screening, good, worked well. The response rate, I've just said, was the same across the groups and was more or less the same in different risk categories. And we've had a good look at the screening performance. In fact, we've done a lot more of this work recently. And this tool has a reasonable screening performance. I think one of the things that we accept with falls screening at the moment is that it's not completely accurate, but this kind of certainly compares reasonably well with other tools. It's short. It was okay. For me, this was fine. Treatment uptake. Treatment uptake was really interesting. We had more people take up the offer of MFFP and slightly fewer take up exercise. But actually, what happened was that more people in the exercise arm ended up having more treatments, because I'm going to just show you what the GPs did in a minute. So whilst there wasn't such a strong uptake, there's more of a story. So what happened? So if we look at the people who were eligible for MFFP, what you can see along this spider diagram, you can see if you track up MFFP 1080 and then you track along again, what you can see is that the most common treatment that the MFFP teams prescribed was medication review. And they prescribed very little exercise, actually. So only 24% of the people that they looked at, they actually referred on to exercise. And they were very selective in who they referred on to exercise. They referred mostly older, frailer women. Now, this was despite having been trained in spotting gait and balance problems, in also using, I think it was the timed up and go test with a, kind of standard, and that was done. But still, there's some, I don't know what it is that happens. I mean, this is what's fundamentally at the bottom of this issue. I mean, maybe it is that people have to prioritize the interventions that they provide because they recognize that patients can't manage all of them at one time. It may be beliefs about the acceptability of different treatment approaches in the clinical consultation, but the result is that if exercise is an effective component here, the choice has been made not to refer on. And people went into the same exercise classes, so we used the same ATAGO format as was used in the exercise arm. So fewer people went to exercise, and then you can see that the other types of interventions that were commonly used. Let's move on a little bit. So this is what came back from the MFFP assessments, and these were the actions that were taken. So we had 460 people who required a medication review, and all of those people got that medication review. 299 were referred for exercise, and 18 were given exercise sheets as opposed to being referred. 50 people were referred on to a falls consultant, and then you can see that people had the option to provide either leaflets or OT referral for environmental stuff. There's very low use of OT actually going around to people's homes. It was almost always done by leaflet. So we have that level of granularity of the treatment approaches. This just gives you some insight into who actually did the MFFP. So as I said, in some areas it was consultant-led service, that's in the blue. Practice nurses, so these are primary care nurses who are trained and kind of do lots of different procedures in the general practices. In some areas we used research nurses who are kind of peripatetic between general practices, so they work for the general practice research framework, and in other areas we used an OT or nurse-led falls service, but they'd all been trained in the approach, and they had all worked with the research team to ensure that there was a mechanism by which all of the elements of the intervention could be delivered. For medication review, I don't think this will surprise you. Despite a reasonable amount of activity, there wasn't a huge amount of change in the medication prescriptions over time. The only thing that happened was there was a slight increase in benzos and some of the hypnotics in the MFFP arm, and there was an increase in vitamin D and calcium prescriptions. Otherwise, not a diddly squat kind of change. So that was disappointing. And this just compares the exercise by treatment arm. So as I've said, we use the same approach in both treatment arms, and actually that worked out okay. You can see that the mean number of contacts in blue is about the same in both of the arms, and the mean number of people who complete, the mean number of contacts for people who complete is also the same. So the statistics, there's a few little differences, but basically if you got to the exercise program in either arm, you got the same thing. And what we also know is that these are the, for people who know the ATAGO program, these are the strength and balance bandings. And the top line is the pre and then the post banding. Green basically means you're strong and red means you're not. And what you can see is that on the ATAGO bandings, the people who came in were reasonably strong, but we did manage to push the strength bandings up and compress that further. And with the balance, the same thing happened really, kind of, we managed to push along that bright green bar so that we went from 23% of people with unable to do the level 1 balance assessment to, we pushed kind of people up quite a long way. But what you can see there is that there's still quite a lot of improvement that could be delivered from balance interventions. So they're not taking people, if this had been totally successful, this bar would be completely green. So I think that's the easiest way to interpret. I'm sorry, it's getting a bit late at night, but anyway. So the interpretation of the process evaluation data was that the screener worked well in primary care. There was some variation in the uptake and kind of different elements of the interventions that were delivered, and I've explained that to you. And we did see a falls reduction with exercise, but it was not sustained in the longer term. But the overall finding, of course, is that there was no difference in fracture rates at the end of the study. So yes, that was 10 years work, maybe even longer, for a study that asks a lot of questions, I think now. I think 2 studies that ask a lot of questions. So these are just to make you aware that, of course, we've got the publication in the New England Journal of Medicine. We have to write to a very tight word count within the New England Journal. There is an extensive appendix which contains a lot of additional information. And in about 3 months' time, we'll have a 250-page monograph, which presents more of this of the detailed information that I've presented today. So that should be out in a little while. Thank you. That's the end of the presentation.
Thanks very much, Professor Lamb. What an amazing achievement to complete such an enormous trial. It's, yeah, quite incredible. So just a reminder to the audience that if you have a question of Professor Lamb, if you can just use the Q&A function and we'll get to as many as we can. But now we'll move to our expert panel members to ask questions and make comments. So I'd like to invite Professor Cathie Sherrington first up. Professor Cathie Sherrington is a Senior Principal Research Fellow at the School of Public Health, University of Sydney, and she's Deputy Director of the Institute for Musculoskeletal Health. Thanks, Cathie.
Thanks very much. And Sally, thank you so much for that talk and also for that amazing trial. It is just incredible. Those of us that have done trials really appreciate the complexity and the amount of work involved. So well done. So I guess I had 2 things that I wanted your input on, which I guess were differences that I'd spotted between, you know, the way things worked in this trial compared to other trials. And so, you know, our Cochrane review on exercise for falls prevention also found a 25% reduction in fractures, but, you know, not fully certain about that. In terms of the grade system, and the Otago home exercise program. So their meta-analysis of their trials actually had a 35% reduction in falls injuries as well as in falls. And so there was sort of 2 things that I spotted that perhaps were a bit different about your trial that I wanted your input on. So first of all, with the delivery of the exercise. So as I understand it, with the Otago original trials, they were actually home visits, which focused on teaching the home exercise program in the person's own home and presumably, you know, in the spot where they were going to be able to do the exercise. As I understand it, that's not what you did in your trial. So that's the first thing I'd like you to comment on, but I'll tell you the second thing first. I think you can remember. And the second thing is about the recruitment. So as it seems that people didn't necessarily agree to participate in a falls prevention intervention. They seem to be agreeing to participate in a survey about ageing. And so I was wondering if that might have impacted the sort of behaviour change and really the commitment that people had to participating in the intervention. So,
yeah, okay. So let's take the last one first. This is a real world trial, and you know, kind of we have to, the whole purpose of this is to see how this works when you implement it in everyday practice, and people taking up, you know, agreeing to adhere to, and all of the rest of it. Yes, they are bound to be different, but they are actually the truth of the situation. When we recruit people to when we recruit people to randomized trials, I was going to say particularly individually randomized controlled trials, you know, these people are kind of very often, they've been through a sieve before they even get into the study. So they've got to come through the sieve of, you know, are they exactly the right type of person? But then also, are they happy to join a trial? You know, kind of not everybody is happy to join a trial. I think certain types of people join trials, and unfortunately we don't have a massive amount of information on that, but I think it, you know, kind of it doesn't seem to be that wouldn't be the case. So I think we do get a rosy estimate from clinical trials, and when they're generalized or tested in the more general population, then, you know, kind of sometimes things work and sometimes don't, and this is about scaling up. So yeah, you know, I personally don't think can be a criticism of the finding. Rather, I look at it like, okay, so that works really well in a kind of small, very tightly controlled trial. And, you know, some of the people who've done this work are the very best physicians in the world. And they have run these individually randomized controlled trials very tightly on their own patch, with their own teams, with their own level of commitment and with their own skill, you know, and it's the skill and commitment that comes together. And these people who delivered for us in this study, they have stepped forwards to be part of it, but then they're not as, you know, kind of like, it's not of the same ilk. So that's my feeling about that. Does it matter that we didn't go to people's homes? Well, to be quite honest, in the UK, we can't afford to go to everybody's home. If everybody who is at risk of falling, we just don't have that type of service, quite simply, and we never, well, I don't think we ever will, particularly now that we're post-COVID. I can't see that happening anytime soon. So this is the most usual format in which the ATAGO is delivered. One thing I did forget to say is that if people wanted to deliver this in groups, they could also deliver it in groups. So again, we kind of left some flexibility around it. Yeah, you know, possibly if it was delivered at home, you know, you don't know what else people are picking up when they go into the home as well. And I think that probably, if I remember rightly, Cathie, some of the original ATAGO studies were more intensive as well. But yeah, it's just not possible. I think what we've shown here is that certainly using the approach we use in the UK, if we think we're preventing fractures through this approach, we're not.
Thank you. That's good. We'll move on. Thank you.
Okay, so we'll move now to invite Professor Naganathan to comment. So Professor Vasi Naganathan is a Professor of Geriatric Medicine at the Concord Clinical School, University of Sydney, and the Centre for Education and Research on Ageing. So over to you, Vasi.
Thanks, Sally. I mean, this is probably a landmark practical trial, real-world trial in older people. You know, it'll stand, I think it'll be looked as a landmark trial, practical trial in older people. In a way, where do we go from here? So policy people might look at this and say, well, they could say, well, this shows that it's, you know, it's really hard to implement falls prevention strategies in the real world. And therefore, well, the osteoporosis fraternity might say, well, let's keep this simple, give them the osteoporosis drug. We know that prevents fractures. So where do we go from here, both in terms of policy and practice and future research studies?
Yeah, so in terms of policy and practice, what we have said as a kind of interim stop point, what we're hoping is that we will have another revision of the NICE clinical guideline for falls prevention. So at the moment, we knew that these two big studies were coming, and you know, they're far bigger than any of the studies that have individually looked at fracture rate, and hence they've got a much more reliable estimate of what is happening. We've now got two studies that kind of are backing each other up, as it were, you know, kind of like showing this effect. So certainly we want to go back and revise the NICE guidance. We have said that people should continue to exercise for the time being, and actually we have said that people should just continue until we do the NICE revision. As a researcher, this is probably one of the most difficult situations you can find yourself in, actually, is when you kind of have got a study that doesn't deliver the result that people feel that comfortable with, but is nevertheless important. I feel that this should undergo independent scrutiny, and that the guideline panels, you know, are best placed to look at the entire body of evidence. So that's certainly where, you know, kind of how I feel about it. And like I say, we've suggested that people continue for the time being, but it has thrown things into a bit of a spin in the UK. In terms of research, I think this really stimulates a new research agenda, and there's many agendas here. The one that kind of really struck me was that actually I don't think we do. Falls prevention doesn't reduce that many falls. You know, there's still 75% of people falling, and we don't know, you know, kind of like within that, can we know, well, we do know this, we find it much harder to move people from being a faller to a non-faller, as opposed to reducing the kind of overall fall rate. So my sense is that exercise interventions, they're a start, but they need to be much more potent, and we need to be thinking much more about the kind of retraining the sensory motor system. So what we did notice in the study here was that quite a number of the fractures occur in situations outside the house. They occur in unusual situations, and I don't think that our rather simple kind of home-based exercise program prepares people for those eventualities. So these are things like, I mean, the thing that really took my eye was that quite a number of the fractures are occurring in situations where we've got moving environments. So things like escalators, moving walkways, inside shopping centres. You know, they're kind of like, they're not the things that we've got necessarily on our mind when we've been training people. So we will start a new programme, we hope soon, looking at some of the more kind of lifting the level of challenge in the balance training program, and also hopefully compressing the amount of exercise and dedication that older people have to give to these programs to get the benefit. So we'd like, I just call it more potent, you know, something that's much more potent than we currently have. And I think the other thing that's happened is that we have kind of rather assumed this link between falls and fractures, but we already know that there's a number of other important risk factors for fracture that we don't target very well at the moment. So things like alcohol consumption. I had a little think about violence, which is not something that I often think about with older people, but I should think about more. So I just think we need to take a step back and think a little bit more clearly, you know, try and think a little bit more clearly about why fractures are occurring. Have you got any thoughts? I'm very interested to hear if people got stuff too.
I mean, it raises a question. So there wasn't much change with medications. So that opens up the whole research and practical implications of the deprescribing literature, which I know some of, and that challenge, right? So that goes on one path. Actually, you didn't show data about osteoporosis treatment. Then there's the whole body of literature to show the under-treatment of osteoporosis.
Yes. So we very purposefully didn't target osteoporosis here because I wanted to have a look at the effects of fall prevention, not osteoporosis management. And I think that was the right thing to do with hindsight, because the other study that came out a little while ago was the, oh God, I'm not going to be able to remember the name.
The Lancet Stroop study?
Yes.
Yeah.
Yes. So, you know, kind of there is some evidence around there on the management of osteoporosis and fracture as well. So, yeah.
Okay, and we'll move to Professor Stephen Lord for a comment. So Professor Stephen Lord is a Senior Principal Research Fellow, and he's the Centre Director for the Falls and Balance Injury Research Centre at NEURA. Stephen, do you have a comment or question?
Yes, I do. Thanks very much, Sally. My question is, hi. How would you contrast the multifactorial component of your study with STRIDE? I guess in terms of its content and also in terms of maybe the limitations. I know, for example, in STRIDE, one of the issues was not actually being able to put many of the interventions in place.
Yeah, I think they have a slightly different challenge. So as we set off along this road, my anticipation had been that we may not see an effect from MFFP in our study, but I would have thought that Tom Gill and his team would see an effect. And the reason that I thought that was because he put a lot of additional money into quality assurance. So where we had kind of quality assurance on the trial side, we had some, we went and we quality assured the intervention. But Tom really piled a lot of money into that, so that, kind of it was super watertight. And I had anticipated, therefore, that, kind of his intervention stood a much better chance of being implemented to a higher standard. But of course, I mean, reading between the lines, I think that the types of challenge that he faced were in his participants couldn't get reimbursement for some of the elements of the intervention. That's not the case here. So no patient in this study, or no participant in this study, was denied access to really any of the treatments because of an inability to pay or to get reimbursement. This is all, there's a few little bits that you could nitpick around, but predominantly this is all delivered by the NHS. So that's not an issue for this study. So yes, there are some similarities, but there's also some important differences. And I think here in our situation, what you probably see more of is people's personal choices. Kind of the practitioners were trained to obviously encourage people to take up these interventions, but people make personal choices about whether or not they go. I mean, some of them may be logistical choices, but I think the uptake was reasonable for the people that we sent through. But kind of evidently there are some people who don't want to do it. I think we've already always known that.
Okay. My other question is going back to John Campbell and Claire Robertson and their idea that if you're going to do fall prevention, do one thing and do it well. So I think you can't really see it very clearly in the paper, but your intervention, the exercise intervention, did prevent falls in the first year. Yeah. That's true. So we did get that effect there. What do you think of that premise to, just do one thing and make sure you do it correctly rather than overwhelm people maybe?
Yeah, no, I think absolutely. So I think one of the problems with the multifactorial fall prevention is that there's distraction. You kind of assume that you're adding more accuracy when you pile up these risk factors, but in fact, you may be just adding more error. And if you're overloading either both the clinician and the participant with too much intervention, it becomes overwhelming, kind of. So I agree completely. It becomes overwhelming. And also I wonder if this is why people recourse to what's the most comfortable aspect of their practice, kind of it's the easiest thing that they can kind of do. So they do that element, and then the other elements are less familiar. So yes, no, I do agree. I think concentrating on one thing, for me, it would be exercise. I think that it's important that if we increase the amount of contact time, I think we have to recognize that the effectiveness has to also increase in a linear way, because otherwise it's not going to be cost effective. Certainly in the UK, the government is not interested in paying for interventions that are not cost effective at its threshold of willingness to pay. So I think we have to ensure that as we crank it up, we get an additional effect. And I have to say I'm skeptical about that. I'm skeptical about it just in terms of, unless we change the mode of exercise, I don't think that will happen. But, that's an open question.
And a question for research.
Definitely.
We might just sneak in one question from the audience before we run out of time. So a slightly statistical question. So the question is, the follow-up rate is very impressive, but loss to follow-up is large relative to the number of people experiencing fractures. Are you convinced that small differences in fracture rates are not obscured or exaggerated by loss to follow-up?
So there is no loss to follow-up with the fracture data. It's all entirely collected from routine hospital and NHS digital hospital episode statistics. So what happens, as I'm sure happens in Australia, is that if anybody goes into the hospital and has an admission, that admission is recorded and stored in the NHS digital data with the reasons for admission. So you've got the kind of, you can have as many reasons as you wish to, but the fracture type and the ICD-10 code is all coded up. And likewise, if you go to the emergency department, the same thing happens. The coding isn't quite as good, it's getting better, but we could work our way through that. And if you go to the fracture clinic, you also get a code. So that is complete data. We double checked in general practice. Sorry, I hope you're not seeing my strange things happening to my screen. Yeah, so I'm very happy that we've got complete data on the primary outcome. We've got one person who withdrew their consent for us to access their records, that's all.
Okay, fantastic. Well, we might have to wrap it up now because we're out of time, but I just wanted to thank Professor Lamb very much for taking the time to present today. Thanks to our expert panel members. And I also need to thank the Australian and New Zealand Falls Prevention Society who co-hosted this webinar. And I'd like to wish everyone a safe and restful Christmas break. And bye.
Oh, yeah. Yeah, thank you very much for having me. I've really enjoyed it, and I only wish I could be with you.
Thanks, Sallie.
Thanks, Sallie.
See ya.